Good morning and welcome to this session on bread and butter and not so bread and butter EUS. I'm Gibran Aboud from the University of Arizona, and this is my colleague, Dr. Piniella from the Mayo Clinic Scottsdale, who will be moderating this session. Our first speaker really needs no introduction. She's a world authority in precancerous pancreatic lesions and the detection of early pancreatic cancer. She currently serves as the chair of medicine at UPMC, previously the director of gastroenterology and hepatology at Johns Hopkins. And she'll be talking today about EUS imaging and sampling of pancreatic cysts. Dr. Lennon.
Thank you very much. It's an absolute pleasure to be here. Excellent. Okay, I have no relevant disclosures. So let us look to the future. So you've got through DDW, or next Thursday, it's 11 o'clock in the morning, and then you're in your clinic and this patient turns up and they have a 2.7 centimeter cyst. So what we're going to talk about in this over the next 15 minutes is what is our approach to this from the perspective of an EUS, what can we send the tests for, and what else is there to do. So let's start with the first. What are the key questions that we need to know? So I think question number one, what type of cyst are we dealing with? Number two, if this is an IPMN or an MCN, is there high-grade dysplasia or invasive cancer in it now? And if no, what is the risk of high-grade dysplasia or invasive cancer developing in the future? So if we look at this, so if you can tell what type of cyst you have, for example, you know that you can work out your patient has a serous cyst or a pseudocyst, then we know that there's no malignant potential and you can confidently tell your patient they don't need any further surveillance or follow-up. In contrast, if you think your patient has a pancreatic adenocarcinoma, this obviously needs surgery. And finally, in the middle, we have IPMNs and MCNs, which combined are called mucinous cysts. The vast majority of those will not develop pancreatic cancer and can undergo surveillance, but a small number will develop high-grade dysplasia or cancer, in which case you're going to need to have surgery. So how are we going to start? Your patient's going to turn up with a CT or an MRI. And here's a beautiful example of a branch duct IPMN, and you can see this lovely communication. And I put this up because it's not always like this. And so there was a study in over 850 patients, all of whom underwent surgical resection, and they looked at the imaging both beforehand. And what you found was that over 50% of IPMNs were not reported to have communication with the cyst, one of the classic features that we look for in identifying a branch duct IPMN. And if you looked at the serous cysts, 12% of them had a dilated duct, which again you would say is atypical, and 17% were multiple. And I put this up to highlight that imaging, serous cysts don't always follow the typical things that we expect in terms of, IPMNs with communication with the duct and serous cysts being single with no communication. And the reason that that's important is because it impacts our patients. And so if you look at large surgical series, just over 20% of patients that we resect are found to have a benign cyst, and in hindsight, probably didn't need surgery. And there's a recent large study in over 1,400 patients with IPMNs who underwent resection, and you can see that over 50%, even at the top centers in the world, had lower intermediate grade dysplasia. And again, if we'd known, we could have continued to watch them. So how can the EUS help? So let's start with the first question of when should we do it? And I'm happy to talk about the multiple different guidelines and the questions if you want, but I'm going to take a practical approach, which is I would do EUS when it alters your management. So if you have an elderly individual with multiple comorbidities, I would have a very high threshold before I would do EUS. In contrast, if you've got a young lady here on the right, who happens to be my sister, I use those pictures, who has a cyst, a 2.7 centimeter cyst, I would say, sure, let's do the EUS. If we find that we've got a serous cyst, you can discharge this lady, tell her, great, we don't need to see you again. Okay, so let's look at the first question. How good is EUS at telling you what type of cyst you have? And this is a prospective study from the Dutch group, which found that the EUS can differentiate mucinous cysts, that's IPMNs and MCNs, from other types of cysts with 78% sensitivity and 67% specificity. Okay, so second question, how good is EUS at identifying high-risk lesions, for example, a mural nodule? And this is a study from the Mayo Group, which looked at consecutive CTs and EUSs and found that EUS had high sensitivity of 75% compared to 47% for CT, with similar specificity for identifying a mural nodule. And a recent multi-center Japanese study involving 11 tertiary referral centers in 240 patients found very similar results, with EUS detecting 83% of mural nodules compared to 53% in CT. Okay, so you do your EUS. What are the things we want to look for? So we want to look for, one is for high risk or worrisome features. That is a pancreatic ductal dilation. And here you can see this is an example of a dilated main pancreatic duct with some cysts, so a mixed type IPMN. And very importantly, we're going to trace that duct down, make sure that there's no transition point, and our job really is to make sure that there's no solid component or we don't have a small pancreatic cancer. What else are we going to look at? Please remember not to forget about concomitant pancreatic adenocarcinoma. So it's late in the day, you got small cysts, you look at the cyst. Remember to make sure you look at the rest of it. So this is where you have a cancer that arises distant. So you could have small cysts in the head and the cancer could arise in the tail. So please remember to have a look at the entire cyst, at the entire pancreas. Okay. And these are more common in patients with a family history of pancreatic adenocarcinoma, and can also are seen in patients with small pancreatic cysts. So let's move on, and then we're going to have a look at our cysts. So we're going to make sure that it's well defined. We want to make sure that there's no thick walled or thickened septations. And then we're going to see, is there a solid component within it, a mural nodule? So we've said that EUS is more sensitive than either CT or MRI at identifying a mural nodule. But if you find one, what's the correlation with high-grade dysplasia or cancer? So the group from Verona, led by Dr. Marshigani, looked at this, and they did a systematic review and meta-analysis and looked at almost 2,300 patients who'd undergone contrast-enhanced EUS. And what they found was that the presence of a mural nodule was associated with 63% sensitivity and 75% specificity for high-grade dysplasia or pancreatic cancer. If you see it, you want to measure the height, not the width, not the maximum diameter, but the height. And then you're probably going to ask me, well, what's the number that you're looking for? And the answer is there's huge debate over it, and nobody knows. But the bigger it is, the higher the risk. So you can see an odds ratio of 2.9 for a mural nodule of 5 to 10 millimeters, and an odds ratio of almost 8 if it's bigger. Okay, so I think everybody who does EUS knows the critical question, which is that if you see something in a cyst, not all lesions are mural nodules. So how do we differentiate a mural nodule from mucin or debris? And I find this study very helpful. So on your left-hand side, you have a mural nodule. On the right, you have mucin. And if you look at the mural nodule, it's got an irregular edge. If you look at the mucin, it's got a smooth edge. If you look at the mural nodule, it's iso or hyperechoic compared to the tissue. In contrast, if you look at the center of the mucin, you can see it's hypoechoic compared to the tissue. You can see, if you look at the mucin, you can see that there's a hyperechoic rim, which is absent on the mural nodule. And if you have all three features, it has an accuracy of 90%. I think nowadays, one of the most useful and important ways to identify a true mural nodule is contrast-enhanced EUS. And this provides information on tissue microvascularization and can differentiate between an enhancing mural nodule versus a non-enhancing solid component such as mucin or debris. It can be performed with color Doppler or contrast-enhanced harmonic mode, which is superior. And hyper-enhancement. So here you can see on the left-hand side, you can see we have this mural, we have a lesion within it, and you can see after the contrast, you have this hyper-enhancement, which is suggestive of the presence of high-grade dysplasia or a small cancer. This is a systematic review and meta-analysis of just over 500 patients, and what it shows is that contrast-enhanced harmonic EUS has excellent sensitivity of 97% and specificity of 90% for identifying high-grade dysplasia or invasive cancer. A couple of little points about this. This looks incredibly promising. Of note, almost all the patients enrolled in the study had underwent surgical resection, therefore the specificity may be a little bit higher, and there were no randomized controlled trials with a large number of retrospective. But I think either way, contrast-enhanced EUS is incredibly important and a very, very useful tool. Okay, we've talked a lot about EUS. What about FNA? When should we do it and what are the risks? So again, in terms of when should we do it, I'm going to say when it alters your management. Here on the left, I think this is, for me, this image looks very classic for a microcystic serous cyst. I'm not sure, I don't think you probably need to biopsy that. In contrast, this cyst on the right-hand side, I really don't know what it is. I could guess. It could be an MCN, it could be a macrocystic serous cyst, maybe it's an IPMN, but really it's a guess. So what are the risks of EUS FNA? So this is a large systematic review and meta-analysis in over 10,000 patients, of whom 900 had a pancreatic cyst, and the risks are low. Pancreatitis just over 1%, the risk of infection, fever, or bleeding 0.3 to 0.4%. I think one of the things that worries many of our patients is what is the risk of peritoneal seeding. This is a very nice study where this group looked at patients who had EUS FNA and then went to surgery, or patients who went straight to surgery. And what you can see is that they found the risk of peritoneal seeding was 2.3% in patients who had EUS FNA and was 4.4% in patients who didn't. So our message to our patients is, can it occur? Yes. But I think that the risk is small, and if you look at systematic reviews and meta-analysis, the risk is 0.3%. Okay, what about antibiotics? And so there's emerging data that has challenged the conventional approach to antibiotic prophylaxis in patients undergoing EUS FNA. A recent multicenter randomized controlled trial from Spain enrolled 226 patients undergoing EUS FNA of pancreatic cysts and found that the infection rate in patients receiving antibiotics versus placebo was similar. A subsequent systematic review and meta-analysis reported similar infection rates in those receiving antibiotics and versus placebo, and a meta-analysis which included the randomized controlled trial as well as 5 retrospective studies looking at just over 1,700 patients noted no difference in infection rates between patients receiving antibiotics and those who did not. And this data and others suggest that routine prophylaxis with antibiotics is not justified. There is, of course, a proviso, which is that I think prophylactic antibiotics should be considered if you aspirate cysts in immunosuppressed patients and those with multiple comorbidities where infectious complications could prove dangerous, particularly if cysts are incompletely aspirated or ascites is present. Okay, so we've spoken about it. What should we send our tests for? So here's my cheat sheet, cyst fluid CEA and glucose. So a high cyst fluid CEA greater than 192 or a low glucose less than 50 is associated with an IPMN or an MCN. If you have a low CEA less than 5 or a high glucose greater than 50, it suggests that you're dealing with a non-mucinous cyst such as a serous cyst or a pseudocyst. If you send cytology, you want to look for mucin, would suggest that you've got the presence of an IPMN or MCN, and you also want to look for high-grade dysplasia. So how good is cyst fluid CEA? So this is a large systematic review and meta-analysis, and you can see that it's not that good. The sensitivity was 58% with a specificity of 87%. What about glucose? Well, here, again, smaller number of patients. However, you can see that the sensitivity and specificity look very good at 93 and 89%, respectively. Okay, well, what other tools do we have? Well, we have through the needle biopsies. This is where you have a 19-gauge needle, you put it into the cyst, and then you put your biopsy forceps through, and the concept is that you can get a larger chunk of tissue, and this will help you in your diagnosis. We also have needle-based confocal endomicroscopy, which will provide real-time imaging of your cysts. And here you can see a beautiful example of mucosal epithelium consistent with an IPMN. And on the right-hand side, superficial vascular network, which is consistent with a serous cyst. So how do these compare? So let me walk you through this large systematic review and meta-analysis, which looked at just over 1,000 patients who had either through the needle biopsies or NCLE. So there were 11 studies in the TTNB section versus 9 in the NCLE. The number of patients was a little higher in the TTNB, 581 versus 482. The big difference was that 2 of the 11 studies in the TTNB were prospective. In contrast, 7 of the 9 in the NCLE were prospective. The mean cyst size was very similar, 3.2 and 3.4 centimeters. So how good is it? So in terms of technical success, it was excellent, 94 and 99% respectively. What about diagnostic yield? Again, fairly similar, 77 and 85%. What about identifying mucinous from non-mucinous cysts? Again, very similar, with NCLE having a slightly higher area under the curve of 0.91 compared to TTNB of 0.886. The gold standard, of course, is surgical pathology. So how do these two modalities compare with surgical pathology? And you can see here that TTNB so in the 104 patients in total where they had surgical pathology, you can see TTNB had a concordance of 0.82 with the final pathology, and NCLE had 0.65. Of note, the number of patients available for the gold standard was low, just 10%, and there were wide confidence intervals. I think one of the big things is the adverse events. So you can see here that it's relatively low, 5% for TTNB and 3%. But one of I think the key things is that the risk of moderate adverse events is 1.3 and 1.5%, and severe is 0.7. If you look at this in a little bit more detail, this is a prospective study from 2021, and you can see that the adverse rate was 10%. And there's a more recent study, which is also a prospective study, which looked at just over 100 patients, and the adverse rate was 10%. Of those patients, 9% of the patients got pancreatitis, of which 4 were severe and 1 were fatal. So I think that this is an important thing for all of us to be aware of. Finally, let's talk about molecular markers, and I'd like to thank Dr. Atra Singhi for sharing these lovely slides with me. So this is how do molecular markers work in real life? And so this is a study looking at 22, so this is a 22 DNA-based next-generation sequencing panel, which looked at almost 2,000 patients from 31 centers around the United States. And this is real live data. How does it work in real life? It had 98% technical success. There were 1,200 patients, or just over 65% who had follow-up, and of the patients, approximately 20% underwent surgical resection. So how good are they at identifying benign cysts such as serous cysts? So here's the answer. If you have a VHL mutation, it has exquisite specificity of 100% and 71% sensitivity for identifying these patients. What about identifying IPMNs and MCNs? And the answer is, if you have a GNAS, a KRAS, or a BRAF mutation, you have 90% sensitivity and 100% specificity for identifying an IPMN or an MCN. And when you look at how does this compare to other modalities that we use, viscosity or CEA, it was significantly better. Okay, we know it's an IPMN or an MCN. How good are we at identifying high-grade dysplasia in these patients using molecular markers? So if you have any of these mutations, a P53, a SMAD4, a CTNNB1, or an mTOR gene, which is shown in the right-hand side, you have 89% sensitivity and 98% specificity for high-grade dysplasia. And again, this is in real life compared to the gold standard surgical pathology. And when you look at how does this compare to imaging, things that we typically use, a dilated pancreatic duct or a mural nodule, you can see that it's significantly better. Or if you look at cytology has very good specificity, but the sensitivity is only 46%. And finally, none of the other patients develop pancreatic cancer. So in summary, if you want to take this home, if you have a VHL mutation, this is a serous cyst and you can discharge your patient. If you have a GNAS, KRAS, or BRAF mutation with no other mutations, this is an IPMN or an MCN, and those patients can be followed. And if you have that with a TP53, SMAD4, CTNNB1, or mTOR mutation, you must be concerned about high-grade dysplasia and consider surgery. Finally, this was published in 2023. There's now over 4,000 patients which have been followed. And one of the most incredibly exciting things, I think, is looking at this data of serial sampling in the same patient. And Dr. Singhi has very kindly shared this unpublished data with me. So we think that in early, GNAS, KRAS, and BRAF occur early, and you have these other mutations occur late with high-grade dysplasia. But what we now have is quantification and looking at the amount of mutation that's present. And what we're now seeing in a small number of patients with serial data is that you can have a small level, for example, of TP53, which is lower than the GNAS or KRAS. And if you send these patients to surgery, they've got low-grade dysplasia. But we think if you follow them, that those patients are at very high risk of developing. So our third question was, if you have a patient who doesn't have high-grade dysplasia, what can we identify those individuals who are at high risk of developing in the future? And we're starting to see information which may help us identify those patients. So we've come a long way, and I think we've got further to go. The most important thing as we look to the future is having high quality data, and it's wonderful to see multi-center prospective studies, and I think we've seen how impactful that these can be. There are other studies that are going to come out in the next 1 to 2 years. Sam Krishna at Ohio State is leading the CLIMB study, which will report on 500 participants and let us know how accurate is NCLE compared to molecular markers. I think you've also seen how the increasing complexity that we have, and I think there's a huge opportunity for AI to help us and our patients determine what is the risk, what type of cyst they have, and what is the risk of developing cancer. And finally, I think the next question is, how do we identify those individuals who have low risk of IPMN, low risk of progression, who need minimal or no surveillance? Thank you so much.
Thank you, Dr. Lennon, for that excellent talk. Our next speaker is well known to all of us. He is a professor of medicine at Penn State, and his research projects include the NIH-funded CHARM trial. He will be talking to us about the chemoablation of pancreatic cysts, which is a not so bread and butter topic. Dr. Moyer.
I want to thank the course organizers for asking me to talk about this very exciting, minimally invasive treatment option for mucinous-type pancreatic cysts. And it's an exciting time to share it with you during an era of wider adoption. When I first started talking about this in 2017, it was a voice in the wilderness, but now we just finished training our 12th center on how to do this, so I'm excited to share it with you at this point. So let's, not a whole lot of time, so let's talk about this, and we'll go pretty quickly, and I'll apologize for that. I think what bears mentioning in the very beginning is that pancreatic cancer, generally speaking, comes in two versions. You have the microcystic or microscopic ductal adenocarcinoma that we're all familiar with, which tends to happen in the periphery of the pancreatic ducts. It is a early aggressive lesion. It's difficult to pick up and it's difficult to treat and has those dismal outcomes we've all become familiar with. Separate from that, we think about 20% of pancreatic cancer comes from this mucinous pathway. This is a different molecular profile where these cysts pick up. And remember, not all cysts go on to do this. Most cysts are low risk and will never do anything. But some will pick up oncogene deletions, tumor suppressor gene loss, and will develop more and more dysplasia over time, and will eventually, over a period of years, develop adenocarcinoma. So anybody in the audience can kind of see the similarities to colon polyp, to colon cancer adenocarcinoma, and that gives us an opportunity to interrupt this sequence. So first of all, I think it bears mentioning that almost all mucinous cysts are low risk. They're less than 2 centimeters, they're low risk, and they are just best followed by surveillance, MRI surveillance, using the ACG guidelines. So I just mentioned ACG, and I'm shamelessly pandering to you with that. But that is just all you need to do, and that's mostly all pancreatic cysts. Now, it bears mentioning as well that surveillance is also, I should back up a little bit, it's non-therapeutic, right? It's expensive, and there's really no prospective data to even show that it truly works. So you have to keep that in mind. Surgery. If you have a cyst that has stigmata of malignancy, you're looking at it and there are signs that overt cancer may already be in place. That is the role of surgery. This is when Kelly comes into the scene and we're going to rely on her to resect what may be a cancerous lesion. However, we have to appreciate that even in high volume centers, you're talking about a 1 to 3% risk of mortality, 20 to 4% risk of serious morbidity. Those patients are never quite the same. And we want to hopefully get to a point where we can reserve that kind of treatment for lesions that are consistent with malignancy. For lesions that are in the middle ground, it would be excellent if we could remove a resective strategy with its morbidity, mortality, and cost with a less invasive treatment option for this middle ground patient. They no longer have a small cyst that's best for surveillance. They don't have stigmata of malignancy, but they have a lesion that's technically amendable to ablation and in that middle ground. And Kelly, I'm sure you're looking at that going, I should show a robotics picture, not a dramatic open surgery. And I probably should, because surgery, frankly, has become less invasive over time as well. So how does this work? Well, it's more complex than this, but generally speaking, you do a full EUS exam and you put a needle in the middle of a target mucinous cyst. You remove all that mucogenic fluid, leave a small rim of fluid around the needle tip for safety, and you simply reinfuse your ablation cocktail using the same amount that you removed. You reconstitute the cyst to its original size and dimension. Over 12 months, that cyst will ablate over time, and it does take 12 months. This is not something that happens quickly like radiofrequency ablation of Barrett's. We're not the first guys to come up with this. Bill Brugge's group was the first to try alcohol ablation of pancreatic cysts. So the needle went in, they ablated that, they lavaged that cyst with 98% dehydrated alcohol for 3 to 5 minutes. I can tell you it's the longest 3 to 5 minutes of your life. And they showed in other studies as well, they have a mild efficacy, 9 to 35%, but the South Koreans came up with the innovative idea of after that alcohol lavage, what if we removed the alcohol and we replaced it with 6 milligrams per milliliter of paclitaxel? You can see that the ablation rates go to 50 to 79%. That's true efficacy. The problem? Anytime you use alcohol in an ablative strategy, you have between 4 and 10% risk of serious adverse events because of the inflammatory and toxic nature of alcohol. This is not the alcohol you're going to have in your beer tonight when you're getting together with friends. This is 98% dehydrated alcohol, very toxic, very inflammatory. So that's when we came up with the randomized prospective CHARM trial. We wanted to push 2 concepts. 1, is alcohol even required? And 2, if we could get rid of it in the ablation process, would adverse event rates fall? We randomized patients to 2 groups. 1 underwent alcohol lavage for 3 to 5 minutes. Alcohol was removed, and then a ablation cocktail that was specifically designed for pancreatic neoplasia was then infused. The experimental group, they had saline lavage. That was then removed and the ablation cocktail introduced. The outcomes are percent of patients who had complete response at 1 year by MRI and serious and minor adverse events within 30 days of the procedure. You can see up here at the top, can you see my, no, you can't see my, all right, we just have to take my word for it. Look at the top, 61% of the alcohol arm enjoyed 61% complete ablation. You can see the alcohol-free arm had a 67% rate of complete ablation. So alcohol is not required for effective pancreatic cyst ablation. But the important part is on the right, serious and minor adverse events. They're entirely localized in the alcohol arms. There's 0% risk of adverse event rates, at least in this study, in an alcohol-free approach. So when you remove alcohol from the process, adverse event rates dramatically fall, paving the way for wider adoption. You've taken the major risk out of the procedure. How do we know if it works? It's always the same. You have an MRI preoperatively and an MRI at 1 year. This is a typical patient who came through the CHARM trial. You can see that this patient has a 2.8 centimeter lesion in the neck, body of the pancreas. We measure that again at 12 months. You can see that this cyst is no longer identifiable. You can't even measure it. That is complete response. These are our results in the CHARM trial. You can see that, and by the way, how do we measure response? It's always the same. There are consensus documents for this, which is measure it by volume. Greater than 95% reduction is complete response. There's also partial and non-response. You can see that most patients have a pretty vibrant response by 6 months, but a full year is required to really determine if a patient had complete response or not. Some patients take that full year. You can also have to acknowledge here that not every patient responds. There are so-called non-responders, just like RFA for Barrett's esophagus and dysplasia or other ablative strategies. So let me say one thing before we move on. So when we published this data, a couple of criticisms came up. And what are they? They fall back on the same things, which is, how do you know it's gone? How do you know that radiographic response means clinical response? How do you know it won't recur? So just like when we started treating Barrett's esophagus with high-grade dysplasia with radiofrequency ablation, that same issue came up back in 2006 to 2008. And the way you solve that, long-term follow-up of prospective data. So here's our long-term follow-up of the CHARM trial, and it shows that of those patients who achieved complete ablation, 87% stayed in complete ablation long-term, which was 3 years in this study. No patient who had a treated cyst went on to develop high-grade pathology in the treated cyst. And in fact, pleasantly and somewhat surprisingly, some patients, about 20% of patients who didn't achieve complete ablation originally, went on to achieve that over a number of years. There was a delayed treatment response. Ablation takes a long time. This is what that looks like in real time. You'll see that a full EUS exam is required. You'll put the needle in the direct center of the cyst. You'll aspirate all the mucinogenic fluid. You'll leave a rim around the needle tip. You'll measure that. The exact same amount of ablation cocktail will then be reintroduced. Make sure there's no air in the line. You simply reintroduce that into the cyst and reconstitute it to its same dimensions. Here's what that looks like in real time. Here's a large IPMN. We're going to aspirate it relatively dry, and you'll fill it with that same amount of ablation cocktail, and you'll get that nice snow globe effect. Here's a cyst that has multiple large chambers, a high-risk cyst. We're going to have to get every one of those chambers if you're going to ablate it. So the first one is aspirated and refilled, nice snow globe there. We'll aspirate a small cyst. We're not going to actually ablate this small cyst. You'll back the needle out to the next larger cyst. And if you've done it right, you'll get this snow globe effect everywhere where the chemo is, knowing where you have had the chemo and where you haven't. It's a nice identification of if you got a good effect or not. Snow globe effect. I coined that, by the way, so you can't run off with it. Okay. So this is a minimally invasive treatment option that's exciting for appropriately selected patients. That's the important issue. Here's a 55-year-old patient who went through the CHARM program, 3.3 centimeter cyst, growing over time. You'll see the enhanced MRI image on the top, MRCP on the bottom. What's it look like in 1 year? This is the main issue. You want to measure volume. You may have a very small speck of a T2 signal where that cyst used to be. That's complete response. Cannot see the lesion on T2. Here is a lovely 82-year-old, one of my favorite patients, 3.5 centimeter cyst. You can see that she's got a large mucinous cyst in the head of the pancreas. It even has mass effect against the common bile duct. She underwent ablation. You will see the full MRI on the top, MRCP on the bottom, and here's her follow-up in 3 years' time. You measure that. I challenge you to find that cyst now. You cannot. That's complete ablation. So is it safe? Yeah, we showed in that data that it has very good safety. In fact, I think Ann pointed out that even EUS FNA has a 1% risk of pancreatitis, right? This is running a much lower rate than other procedures we're very familiar and comfortable with. Most notably, I'll point out the difference with micro forceps biopsies. So, who is appropriate for pancreatic cyst ablation? Well, let me make this point again. Most mucinous cysts are less than 2 centimeters, they're low risk, and they're best followed by ACG guidelines. Conversely, those that have stigmata malignancy need to be evaluated at a multidisciplinary committee in a high-volume center to see if Kelly is interested in doing Whipple or distal pancreatectomy. However, for the cysts that are in that middle ground, those that are technically amendable to ablation, this is the group that we would like to target for this minimally invasive treatment option. And we have consensus documents that were written by an international group, and I have several review articles in the citation if you'd like to see further details. The American Society of Gastrointestinal Endoscopy asked us to put an instructional video together, and we did. You can see that on GI Leap. All right. Here's a technical description. There's a little bit of light on the screen, but I think you can see it. You'll see the indications are white at the top, and you'll see the best cysts for ablation. They look like an egg, right? That's the so-called unicorn, unilocular cysts. Those are very easy to do. But even if they have septations, it's okay as long as you can get all of those cysts aspirated and then refilled with a chemoablation cocktail. As we drop down into the relative contraindications, you'll see the technical relative contraindications are cysts with lots of septations, or the so-called cluster of grapes. Those are very technically hard to aspirate, hard to ablate, and you got to ask yourself if that's worth doing. Finally, the oncologic relative contraindications. If you have features that say this is a higher risk cyst, such as main duct dilation, a mural nodule 5 millimeters or greater, there is pancreatic duct stricture with tail atrophy, there are thick walls, thick septations. This is just like when you do a large EMR for a large polyp and you see a little nice 3 morphology on it. You have to ask yourself, is that technically reasonable to resect, or should that go to the surgeon? This is a case-by-case basis, but a surgeon, a multidisciplinary group should be involved in those decisions. Finally, contraindications, cysts less than 2 centimeters, and those that have stigmata malignancy. I think I made that point a few times. All right, follow-up. What does follow-up look like? We always bring these patients back in 3 months. They get a second ablation if appropriate. And then mostly these patients are going to follow up at 1 year after MRI, 1 year after first ablation with an MRI. We'll get a second one 1 year later, and if it's stable, we will reduce that to every 2 years. That is a greatly reduced radiology surveillance program compared to what guidelines would have done with the same patient. And is that important? This is a publication that we're going to have in GIE this month, showing that a reduced radiology surveillance program after successful ablation is both effective and safe. This is now our longer-term data. I've been at this long enough to have super long data. 52 patients now we're following. We showed that 70% of the time they got complete ablation. No patient went on to get high-grade pathology in a treated cyst. And we showed that we can reduce the amount of radiology, in other words, MRI, to annual surveillance times 2 and then down to 2. We also showed that there's a huge economic benefit to that. If you compare that patient, which is in green, if they went on and continued on surveillance with the same lesion per Fukuoka or ACG guidelines, it represents a huge reduction in cost to the patient and the medical community. Additionally, we interviewed patients in our pancreatic cyst clinic and in our clinical trials and asked them about it. Do they like MRI? Is that a hassle? And what would they think about reducing it if we could do so safely? Well, it turns out patients don't like an MRI. A lot of them get a lot of anxiety, and some of them hate it. They have claustrophobia and other things. And if you ask them how much of an anxiety is it waiting for it to get done, they also don't like that. Interestingly, most of them don't have a problem with the financial component, which was a surprise, but all of them want to reduce it if we can do that safely. Quality assurance and best practices, I'll wrap this up. We think that this should be done and reviewed with a patient in an outpatient clinic where a patient can fully understand all their treatment options, what's going on, and what they might want to do or not do about this, and who they could talk to. We think this needs to be done at a high-volume center with expertise in pancreaticobiliary disease, and we think that it should be done as part of a multidisciplinary program. The physicians doing this really need to be trained in interventional EUS, and it really should be part of a quality assurance program where all outcomes are measured so we can see outcomes as well as anything that needs to be flagged or improved. There are areas of uncertainty, and I do want to acknowledge that. And finally, I should mention there is another option called radiofrequency ablation. This is not as well studied and doesn't have so much prospective data, but there is one prospective data that was done by the Barthard group that showed 66% rate of complete ablation. There's only one of these RFA catheters left, but that's the one they used. 66% rate of complete ablation at 1 year, but they did report 6% rates of serious adverse events, including a perforation. These are the citations, which, there's a lot to this, and you can look at these if you have any kind of interest in this or you'd like to start with your program. And with that, I'm going to wrap it up. I'm sorry if I ran over a minute. Thank you for your time.
Thank you, Dr. Moyer, for that very thought-provoking talk. Oftentimes, for these cysts, adjudicating their nature and determining their management requires a multidisciplinary environment. And in that vein, our next speaker is a hepatobiliary surgeon coming to us from Johns Hopkins University, where she is an assistant professor of surgery, Dr. LaFaro, who will be talking about surgical management of pancreatic cysts.
All right, thank you very much for the opportunity to talk today. So as mentioned, I'm going to talk about the surgical management of pancreatic cysts. I don't have any disclosures. So just like Dr. Lennon said, when we're thinking about surgery, a lot of the key things that we want to think about are what type of cyst is it that the patient is coming to us with? Do we think there's high-grade dysplasia or invasive cancer at that time? And then also what their chances of developing it in the near future. Pancreatic cysts range from completely benign to malignant and pancreatic cancer. I'm going to start out talking about the benign pancreatic cysts just briefly. Serous adenomas, which have no to very little chance of malignant transformation, account for up to about 15% of resected pancreatic cysts. The indication to resect serous adenomas to surgeons are whether or not they're symptomatic, if there is diagnostic uncertainty, and there are some groups that argue that serous adenomas greater than 4 to 5 centimeters should be resected. Now, this is controversial. There is really no data to show for it, but I just am mentioning it because there are groups out there that will resect. The theory behind that is that serous adenomas at 4 centimeters tend to increase their growth rate per year and can ultimately become symptomatic and harder to resect. When we're talking about surgery for benign cysts such as serous adenoma, it's really based on the location. Most commonly, these happen in the body and the tail, and so it's going to be a distal pancreatectomy. I would argue you should really try to preserve the spleen in this case, as it is a benign lesion, and surgeons range from open to minimally invasive surgery. In the head, we really are left with 2 options: a Whipple, which can be done open or minimally invasive, and also an enucleation. In the neck, kind of the same options. I am going to talk, this is very exciting data in the surgical community. Just 2 days ago at our international HPBA meeting, which is in South Africa, the results of the Diploma 2 trial were resulted. These are the initial results. This looked at open versus MIS, which included laparoscopic or robotic Whipples, although 80% were robotic. It was 14 centers, 6 countries. It was a 2-to-1 randomization. It was 192 minimally invasive Whipples and 96 open. And the patients were blinded for 5 days, so their entire abdomen was covered and taped, so they were not able to tell which group they were in, nor could their physicians, the nurses on the floor, the residents, or anyone treating them. What they looked at in this was time to functional recovery return, length of stay, postoperative pancreatic fistula. Now they looked at grades B and C because these are the ones that add time and increase hospitalization stays and readmissions. surgical site infection, and mortality. So they found, and I did not put it on a slide here since it was kind of just in a talk, there was a decrease in length of stay of 2 days, which is pretty significant when in our hospitals, which are completely full. And there was a decrease in postoperative pancreatic fistula rate by 13%. So this is a pretty significant improvement. There was a surgical site infection risk was cut in half in that study, and the mortality was similar. So this is the first time we've ever really been able to show that minimally invasive Whipples have improved outcomes over open, which I think we've all thought for a long time, but have never been able to show with a randomized trial. So now we're going to switch gears a little bit and talk about pancreatic cysts which have malignant potential. These are the most common ones that we see in our surgical practice. As we know, MCNs and IPMNs both have the ability to transform into pancreatic ductal adenocarcinoma, and through a different mechanism than the traditional pancreatic adenocarcinoma that occurs through Pannin lesions. And as a surgeon, what we think about when you have a patient in your office is the risk of having a missed cancer through observation. And I'm not going to talk about observation much as it's been covered very well, versus complication rate, mortality, and changes in quality of life with surgical resection. So when we look at patients with missed cancer, there have been multiple groups that have looked at the overall survival of patients who have IPMN-associated adenocarcinoma versus what we'll call a standard pancreatic adenocarcinoma. On the left was the MGH group, on the right, the Netherlands group. So it's been the same data has been shown in multiple countries that the overall survival of those patients who are found to have IPMN-associated adenocarcinomas are significantly improved. However, I'd say we've really failed our patients at that point, right? If they're coming to us, if we are operating on them and we find a cancer, we have failed them. The whole point is to really find these patients when they have high-grade dysplasia, where we know they have a very high likelihood of turning into an adenocarcinoma in the future, but that they won't need any chemotherapy, and the risk of recurrence is significantly lower. So these are, There have been multiple guidelines. There's the AGA guidelines, there's the Fukuoka guidelines, most recently published in 2024's international guidelines. So in the multidisciplinary clinic, we'll often look at these. I'm not going to go through them. I think everyone knows them very well. There are worrisome features, high-risk stigmata, and those are when they start to have worrisome features and high-risk stigmata are often when they're sent to the surgeon. But when they're sitting in our office and you're talking about a Whipple, which I agree with Matt, can certainly be a life-changing operation, although I argue it has become a much safer operation. But there is a mortality risk of 1%, and I don't think anyone would argue with that, and a hospital stay on average of somewhere between 5 and 7 days, and a recovery of 2 to 3 months before our patients are really feeling 100% back to normal. Now that might be a new normal, but it does take a good 2 to 3 months. So it's time off of work for patients, for caregivers, it can be a significant burden. So I think it's really important that everyone understand, including the surgeons, that we're doing this for a reason that is correct. This is data also out of MGH. They took 810 patients. It's a retrospective study. These patients were operated on from 1999 to 2020, and they looked at the number of worrisome features and the risk of high-grade dysplasia or cancer found in their resected specimens. So if they had 0 worrisome features, there was a 5% chance of finding high-grade dysplasia or invasive carcinoma. Curious to know why they underwent surgery with 0 worrisome features, but might have been. They don't explain that, but it's a very small number. When you have 1 worrisome feature, there's a 22% chance of high-grade dysplasia or invasive adenocarcinoma. And then you get up to 2, 3, and greater than 3. So greater than 3 worrisome features, they found a 100% chance of high-grade dysplasia or invasive adenocarcinoma at the time of surgery. They then also looked at high-risk stigmata. very similar. When you're looking at high-risk stigmata, if they had 0 high-risk stigmata, there's still a 30% chance that they had high-grade dysplasia or adenocarcinoma. And then increasing 1, 2, and greater than 2 high-risk stigmata, there was 2 or greater, there was a 100% chance of finding high-grade dysplasia or adenocarcinoma at the time. So often these patients come to us, we're talking to them about the data, and it's really important for them to understand you're taking, they think, well, I don't have cancer, and you're telling me I need this giant operation that may be life-changing. Why do I need to, why should I do this? And I think it's really important for them to understand kind of all the underlying parts of it. So when we think of IPMN and surgery, we actually think a little bit about, is this a field defect, right? Is this one lesion, but there are things going on in the rest of the pancreas that are at risk? When you're telling somebody that you're going to do a Whipple on them, but the rest of their pancreas is still going to need surveillance for the rest of their life, it can be really hard for them to come to terms with that. So this is a resected IPMN. They can be solitary like this, but also this one is septated, to having multiple different IPMNs within the same specimen and maybe a dilated duct. So what is the risk to them for the rest of the pancreas? If they're going to go through this major operation, what is the chance that they are still going to develop either another high-risk stigmata or an IPM high-risk lesion in the rest of the pancreas or an adenocarcinoma? So this was looking at patients who had undergone resection, and it looked at the risk factors for developing a new high-risk lesion in the rest of their pancreas. And the 2 risk factors really that they found that were significant, one was family history of pancreatic cancer. I think we probably could all agree that that makes sense and that there's probably something, in addition going on. The other is whether or not you found high-grade dysplasia at the time of surgery. Now, that wasn't high-grade dysplasia in your margin, that was high-grade dysplasia anywhere within the IPMN. And this kind of speaks to the fact that there is something going on and that these, in fact, might be a field defect. Also, so when we're talking to patients, they'll say, well, if you take it out, but the rest of my pancreas is still at risk, am I going to need another surgery after this? Or are you going to have to go back and take out the rest of my pancreas? So this is data out of Hopkins, published in 2016. So it looked at patients who also underwent resection and pulled all of the patients who needed re-resection following. So there are 89 patients in this group with high-grade dysplasia. 7 of them needed a reoperation. In that reoperation, 2 were found to have what they call the intermediate grade dysplasia. 2 had high-grade dysplasia, and 3 had adenocarcinoma at the time of re-resection. In the low and intermediate grade dysplasia, there were 7 patients who needed resection out of 188. They found 1 had a Panin, 3 had low-grade dysplasia, 1 had high-grade dysplasia, and 2 had adenocarcinoma at the time of resection. So when we look at this, there were an additional 3 patients in that high-grade dysplasia category that when they returned had adenocarcinoma that was not resectable. It was either locally advanced or they had metastasis, and 2 in that low and intermediate category. Ultimately, in these groups, there were 10 deaths from pancreatic cancer out of 89 in the high-grade dysplasia group, and 3 in that low-grade dysplasia group. Here, so when we look at it total, there were 11% went on to have pancreatic adenocarcinoma in the high-grade dysplasia group and 2% in that low-grade dysplasia group. So I think this kind of speaks a little bit to the fact that there is some bit of field defect for these IPMNs. Often for surgery, we're going after the dominant lesion or the part of the pancreas that looks the most abnormal, and we are leaving some at-risk pancreas behind. So what do we do to try and avoid this surgically? So there are some pictures here. I say these are on the right side is maximally invasive pancreatic surgery. If we really think there is a cancer there, then we're going to do an oncologic operation where we're going to do a full Whipple, clearing all of the lymph nodes in the area. On the left, here you can see that it's actually a robotic Whipple. It has the replaced right hepatic artery, but this is what it looks like when we're finished with this was a robotic Whipple for an IPMN that did wind up having a T1A adenocarcinoma in it. But we do have to think also then about how can we really decrease the risk to our patients. Surgery, as Matt talked about, it does have a 1% morbidity. Robotics has really changed the game. I gave a little bit of data about the Whipple previously. When we have IPMNs as well as benign cysts like serous adenoma, that we think that there is a low risk or low suspicion of adenocarcinoma being found in it. I think we certainly need to preserve as much parenchyma and as many organs as possible in these patients. This was a robotic distal pancreatectomy in one of my patients who had this was for a serous adenoma that was causing compression on her stomach. It was very large. We were able, you can see on the left side of the screen is the pancreatic staple line, and that is the splenic vein coursing all the way along there. The splenic artery is on top, and we're able to leave the spleen in place. In order to really make sure, though, that we do the best operation for our patients, there are some technologies that we are able to use in the operating room to find the margin, right? So we've seen that patients who have high-grade dysplasia and low-grade dysplasia have an increased chance of finding cancer or recurrent lesions later on. The guidelines say that you can leave some low-grade dysplasia at the margin, but you never want to leave high-grade dysplasia. I'm running out of time, so I'll try and speed it up a little bit. So how do we assess the margin intraoperatively? There are three things that we really can use. One is intraoperative ultrasound, where you can ultrasound the duct, especially a main duct or a mixed type, to make sure that where you're coming across the pancreas is not dilated. The other, pancreatoscopy. There's ongoing completed accrual clinical trial by Marco Del Chiaro looking at intraoperative pancreatoscopy, and then frozen section. The guidelines that have been put out say that it's okay to leave low-grade dysplasia, but you should re-resect high-grade dysplasia. I would argue that that would be assuming that there is no adenocarcinoma found in your specimen. If there's adenocarcinoma, then their overall survival is going to be dictated by the cancer and not the high-grade dysplasia that you left behind and the chance of developing a cancer in the future. So this, you'll have to, let's see if it will work. Nope. It is not going to work. Well, you're going to see a surgeon's attempt at intraoperative pancreatoscopy. Oh, is it showing up here? Okay. So this is actually, this was my first intraoperative pancreatoscopy that we did. And you can see there's somewhat normal looking pancreatic duct here. It's not going to allow me to speed it up, but we'll go on to see starting to see some abnormal pancreatic duct as we're coming through here. We actually went all the way into the duodenum with this and pulled back. And this allowed us to make sure that where we're coming across the pancreas, the duct looked more normal. Now, it's a observation, and so whether or not we'll see what the data shows. So the study that Marco Del Chiaro led was looking at intraoperative pancreatoscopy, and what it did is it queried the surgeons on what they thought the margin looked like where they came across with the pancreatoscopy. So we'll see if surgeons were actually able to tell whether or not the duct was normal, and we're comparing it also then with the histology on the margins of the pancreas. So it'll be exciting to see that come out. I think it's definitely an adjunct that will help in terms of fully resecting these lesions. So just as a little bit of an overview of the operative principles, adequate preoperative counseling, which I would argue is the most important thing, and then organ preservation when possible, additional resection only in low-grade dysplasia, only in high-grade dysplasia and not with low-grade dysplasia. So overall, surgical decisions depend on the type of cyst, the risk of malignancy, and the location, and we can use adjuncts to decrease the risk of recurrence. I should have put in some beautiful pictures, format of our patients after robotic Whipples, which you can't even tell they had an operation. Looks like they had a lap chole. So more to come on that. When that minimally invasive data is finally published, I think that will be really game-changing for the surgical community. So thank you.
Thank you, Dr. Lafaro, for that excellent talk. Our next speaker is Dr. Gaddam, who comes from an institution that is near and dear to my heart, Cedars-Sinai Medical Center, where he's an associate professor and also serves as the associate director of pancreatic and biliary research. And he will be talking to us about pancreatic cancer screening.
Thank you. All right, so we're switching gears a little bit here. We're going to talk about pancreatic cancer screening. The data here is much more at an incipient stage, so I'll try to summarize it best I can. Sorry, I'm trying to move forward. I have no conflicts of interest relevant to this talk. So when I first heard the title of the talk, is the juice worth the squeeze? So I was trying to make some scientific sense of it, trying to understand what it is and what perspective are we going to talk from. There are various perspectives to this talk, and here's one that we all go through every day when we see our patients. A patient tells you that they're at high risk, and you're thinking, how can I prevent this? And how can I not allow this patient to get cancer under my watch? That's one way to look at it. But for this purpose of this talk, I realize that everything depends on your perspective, and I'm going to be talking more using a public health perspective, as in, is this screening cost effective? Is it effective to the public? Is it going to serve the public any good? So with that, let me just briefly tell you that throughout the entire talk, I just want to make sure that we all know that pancreatic cancer screening is not recommended for average risk individuals, and that when I say pancreatic cancer, I'm predominantly referring to pancreatic ductal adenocarcinoma. Let's briefly touch upon the guidelines. My goal is not to go into the nuances, but to know that the AGA guidelines recommend screening in high-risk individuals using MRI, EUS, starting at age 50, and then doing that annually to look for cancer or early cancer. ASGE has similar guidelines, as you can see, and when we move on to the NCCN guidelines, you do see the same type of recommendations. So all societies that we've talked about recommend pancreatic cancer screening using EUS or MRI. But how good are these tests? Are these ideal screening tests? In fact, they've been developed for diagnostic purpose, and then we said, well, if you can diagnose cancer, we should be able to screen cancer, and that's why we use both EUS and MRI. But specifically for screening population, there's limited data. There's emerging data, we'll talk about it a little bit. But looking at it from the public health perspective, let's just look at these criteria. So WHO in the late 50s, 60s came up with these criteria, written by Wilson and Jungner criteria. These still are gold standard today, and they form the cornerstone of testing whether or not a certain test is really worthwhile pursuing as a screening test. So they have 10 questions, and we're going to look at this talk from the perspective of these 10 questions. So let's start out with the number one question. Is pancreatic cancer of public health importance? Yes, we know that. Pancreatic cancer, so if you look at the top end of it, the top half is the incidence and the bottom half is the mortality. Pancreas cancer is the 10th most common cause of cancer, but the 4th most common cause of cancer-related death in men, 6th and 3rd respectively for women. As you can see, the rate of cancer is slowly increasing. The light green color is the incidence rate, and the dark green is mortality rate. The mortality rate has more or less remained stable while the incidence is increasing. This is a 5-year survival rate, And even though it looks really good, once you look at the y-axis and realize that it goes from 0 to 16 or 18, it's pretty dismal. Even though there's projections of improvement, we're only at 12% 5-year survival rate for pancreatic cancer with all comers. Some physicians that I've talked to, they said, well, cancer itself is bad. It's bad for any part of the body. And I'm here to tell you that's really not the case. If you look at the 5-year survivals, these are all 5-year survivals for 3 different cancers: female breast, prostate, and pancreas, stratified by their type of presentation or stage of presentation. It's a very telling story. You can see that breast cancer overall has a survival, 5-year survival of all comers above 90%. Prostate cancer, nearly 96 to 98% 5-year survival rate. And then you go to pancreas cancer. It's slightly older data, but it says 10%. So this following slide graph gives you an idea of why that's the case, and you can look at it. You can look at the stage of presentation and the 5-year survival. Here you can see, the stage at presentation, this is, and you can see that majority of these 2 cancers present at a very early stage. But for pancreas cancer, only 11% present at a localized stage, and majority of these patients are in fact metastatic by the time they present to us. So that gives us room to say, well, there is room for screening and early detection for this cancer. So I would say that's a resounding yes. Going to the next question, is this an acceptable treatment? I think chemotherapy and surgery are considered pretty standard, so I would say yes for an acceptable treatment. The next question is, do we have the facilities to arrange for treatment? This may be applicable to some diseases that we don't have facilities for, but for pancreatic cancer, yes. For diagnosis alone, there are about 40 MRIs per million of the population in the US, just to give you an example. And then the next question is, can this disease be recognized early? That's a tricky question, because it's hard to say without studying it first. So here's some data that supports it, and this graph shows you on the right half is a 5-year survival stratified by stage, and on the left half is what percentage of the patients present at that stage. So if you look at it, the majority of the patients are metastatic. They have the lowest 5-year survival. The minority of the patients, only about 11%, are present at a stage where they have better clinical outcomes. So there's a need to improve that part of the pie, so we can improve survival. If you look at the latest data, stage 1 pancreatic cancer survival is far better, probably around 70-80%, when using the AJCC classification. Here's another important paper recently published in 2022 by the Hopkins Group. And they published their CAPS consortium, which is a multi-center screening consortium started in the late 1990s. And in this data, this is the latest iteration of it. They present on 1,461 patients that they've followed, and they found small number, but a significant 10 patients. And when they looked at their entire consortium of 1,700 odd patients, they found 26 cancers. And in this, what's really remarkable is the pie chart A is the patients in their surveillance program, and pie chart B is their controls. Majority of the patients in screening programs were were detected to have cancer at an early stage, at stage 1. And therefore, if you look at the survival curve, they tend to do better. In stark contrast to this data is the other recent publication, again, 2022. It's a meta-analysis of 13 prospective studies of high-risk surveillance programs. They found that the risk of advanced neoplasia was 3.3 per 1,000 person years. Hard to wrap your head around it, but needless to say, they found that, as their title indicates, more than 50% of these lesions were late stage. So that's not so good data for screening. So therefore, what this gets on this criteria, WHO criteria, is that it's possible, but early stage detection is still challenging. Is it a suitable test? I'd say there are challenges with sensitivity and specificity, so I'd say it's a partial. Is it an acceptable test? I think it is, but yet there are some challenges. It's expensive, it's invasive. Both MRI and EUS can be challenging to some patients. MRI, a lot of patients, as you know, can be claustrophobic. Is the natural history well understood? Again, we understand it partially. We don't know when the tumors start, how long it takes for it to progress to full-blown detectable adenocarcinoma, and how many of these lesions regress over time when they're in their small stage. Those are things needed to be known, but not necessary to take management decisions. The eighth question is there an agreed upon policy on who to treat? I say yes, there are guidelines that tell you what to do, but what we don't have data on is what to do about false positives, what to do about false negatives. We don't have data on what the outcomes are on those false positives and false negatives. That data doesn't exist, and therefore that is a problem and highly clinically variable depending on which tumor board you are in and who you're talking to. Is it economically balanced? This seems sort of the main question, right? Whenever there are policymakers in a room, they're talking about cost effectiveness. And so I'll just show you two studies that evaluated cost effectiveness. This one, both of these studies were published this year. This one is a micro-simulation model in which they took all the known high-risk mutations and using a willingness to pay threshold of $100,000 per quality adjusted life year improved, they found that in men there were only two mutations that were cost effective. That one was CDKN2A and the other was STK11. In women there was just one that was cost effective, and that was the STK11 mutation. And if you look at this real world data from the Leiden cohort, this was based off of 341 patients. They found a cost utility ratio of 14,000 euros per quali, and they concluded that if the lifetime risk of PDACs in a certain high risk group is expected to be more than 10%, then it is likely to be cost effectiveness. So to this question, is it cost effectiveness? Is it cost effective? Yes, it's still debatable. But it's only cost effective in high-risk mutations or the high risk of the known high-risk mutations. Would it be a continuous process? Is it a one and done, or are we going to screen them over time? All our surveillance programs recommend that we do it over time. So in summary, when pancreatic cancer screening is applied to these WHO criteria, we found that only about 4 out of 10 of these criteria were positively answered. That means that there's still a lot of unknown in this area. About 60% of the questions don't meet the criteria for pancreatic cancer screening, or rather are in progress. The research is in progress and in evolution, and we'll find out very soon. So in conclusion, pancreatic cancer is a highly lethal disease with poor prognosis. Early detection through MRI and EUS can significantly improve survival, but comes with challenges. While there are clear benefits, the risks, costs, and impacts need to be carefully managed. Continued research and technological advancements are needed to make pancreatic cancer screening more effective and accessible. Screening should be recommended judiciously, integrated into structured surveillance programs managed by specialized multidisciplinary teams. So where do we go from here? There are several new emerging technologies, and several new emerging technologies that that present as improvements over existing ones. There's a dire need for biomarkers in this area, and we need larger long-term studies to better understand the impact of screening and strategies to minimize costs and minimize harms and control costs. With that, thank you. Thank you for your attention.
Thank you to all the speakers for a fantastic session. Please come up. I think we have about time for 2 or 3 questions, so we'll open it up to the audience. Please come up to the microphones if you have any questions. And while people are, yes, please, Dr. Reichman.
Yeah, Isaac Reichman from Houston. 2 questions. One is for Dr. Moyer and one for Dr. LaFaro. For Dr. Moyer, any issues with us duct communicating cyst in performing the ablation? And for Dr. LaFaro, are you doing preoperative pancreatoscopy for IPMN?
Could I get you to just repeat the first part of the question? I'm sorry.
Yeah, are you having any issues with ablation in patients that have a communicating cyst to the duct, to the main duct?
Understood. Yeah, a fear early on in ablation used to be we had these criteria on ruling out if there was ductal communication, and we came to understand that is really reticent on alcohol getting in the main pancreatic duct, because of course you leak alcohol in the main pancreatic duct and bad things can happen, and of course we wanted to avoid problems, pancreatitis being the principal one. We've gotten away from that. Now with alcohol-free ablation, we don't see that. The paclitaxel, it's a mixture of paclitaxel and gemcitabine. It's very viscous. It stays in the cyst. These are usually mucinogenic cysts to begin with, and we have not seen any adverse events from that. Now, having said that, if you see a lot of intimate communication with the duct, you're probably wise to underfill that cyst when you go to refill it rather than put it under pressure, which might leak in there. But no, we have not seen that issue.
In terms of the preoperative pancreatoscopy, we actually do preoperative pancreatoscopy selectively in patients. If there is a question about the diagnosis, we will ask our interventional GI colleagues to perform it. We do not do it routinely, though, for main duct IPMNs.
Right. Thank you.
Nabin Ordi in San Diego. Question to Dr. Dam. You highlighted a lot of unanswered questions in such an important cancer. If you can highlight one specific effort that should be prioritized the most, and can you speak, I know biomarkers is a whole topic by itself, a lecture, but can you speak briefly on your input and perspective on biomarkers in pancreatic cancer?
Yeah, so I think there's 2 parts to the question, right?
Can you repeat the question? I don't know.
Yeah. So the question was a 2-part question. One was what about the biomarkers? 2 is what is the highest priority in this area? So I'll take the biomarker one first. Is I've seen a lot of biomarkers come and go in this area. There are some promising ones with publications, recent one in Lancet. But it's important to know that I have warned my patient that there's going to be web pages that they're going to look at and think that this is the next best thing and this is the best thing. Those websites are geared towards investors, and our patients sometimes fall onto those. And so at this point, there's nothing that we could strongly recommend, but there are in evolution, and I think it will come soon. Second part of the question, what's the highest priority is in building these cohorts in a very research environment. So if there is a new test, we can validate those tests. We can, evaluate our performance. There's really data lacking on a lot of fronts. So those can be answered if we can build, just like the CAPS consortium, one of the longest running consortia. So I think that is in progress. There's the pre-seed consortium, and hopefully there'll be more.
Thank you.
Dr. Moyer, quick question. What size needle are you using to ablate these cysts?
Yeah, it's a great question, one we get quite a bit, and the quick answer to that is for any cyst that's over 2.5, 3 centimeters, we try to use the 19 gauge needle, the nitinol 19 gauge needle, because The ablation cocktail is viscous. The mucin mucin inside the cyst is often viscous. And you will increase the speed of the procedure, decrease dwell time of your procedure treatment by using the 19. And you actually have to put a little bit of pressure to get this stuff in there. And when you use the 19 gauge needle, things go much quicker. I should mention that this procedure is more of a program than a procedure. And as a part of that, you want a dedicated team. Our nurses, this is what they do. They're on the ablation team. They know how to do it. They know what to do, what not to do, how to handle the chemotherapy agents and dispose of them correctly. And the endoscopy unit looks to them to do this and do it well. And as a consequence, there's a lot of pride on that team for doing it well. To finish your question, though, 19 is what we try to do. Now, as you know, sometimes you can't get a 19 everywhere, like the oncinate, or maybe you're snaking it between vessels or something like that. You can use a 22, but it's a much more challenging procedure.
Thanks. And then, Dr. Lennon, is there any role for targeting neural nodules with the microforceps? As you know, sometimes these patients have a lot of comorbidities, and it's kind of a difficult decision whether you want to send them to surgery or not. And if there's any data that shows that doing this alters management or could prevent unnecessary surgery.
So there certainly is data showing that the microbiopsy forceps do alter management. Depending on which study you read, so certainly they can alter management. And I think my only concern is that those recent prospective studies showing a significant risk of adverse events. So I think that you just need to be aware of that.
And targeting neural nodules with microforceps?
You can certainly, if you're going to do USFNA, I would try to target the most abnormal area, and you can certainly target it with that if you want, or with whatever way you want to do it.
Thank you.
I think we'll end with one last question. This is a bread and butter EUS, so this is a bread and butter question. Dr. Lennon, what do you do with your cytology that comes back as atypical? That's a question online.
So one is I think I'm very fortunate, so I have a wonderful relationship with our pathologist, but that is for me that's really not helpful at all. So I'm looking for high-grade dysplasia. That's what I'm looking for, or marked atypia. They are the terminology that they should use. So I think I would speak to my pathologist, ensure that that's not what they're talking about, and as long as that's the case, I would ignore it.
Got it. Thank you all. Thanks to the speakers for a fantastic session. Really appreciate it.